This is OK News on NewTV. I'm Sam Libenzon. I'm here with Dr. Peter Bach. Tell us a little bit about what you do and a little bit about your background.
Hey, Sam, it's really nice to be here. I'm a pulmonary and critical care physician. I have specialized throughout my career in lung cancer prevention and early detection, or people will often call that lung cancer screening. And I became chief medical officer of Delfi Diagnostics back in 2021 because the company was developing and has now launched a test that can be used to screen for lung cancer among individuals who are at high or elevated risk of lung cancer due to their more advanced age and smoking history. Lung cancer screening's been a focus of mine, as I mentioned, for more than 20 years at this point. And over those years, we've gradually done the right studies, the high quality clinical trials, showing that if you screen for lung cancer among individuals who are at elevated risk, you have the potential to prevent 20 to 24% of all lung cancer deaths in that group.
Oh,
The
wow.
screening procedure today is screening every year with a CAT scan set to a very low dose. A CAT scan is kind of x-ray machine. It's like a donut. You lie on a table, they send you through it. It only takes about 20, 30 seconds to take the scan. But there aren't that many CAT scanners, and you still have to, takes kind of half a day to go and get one. It's worth it because it's life-saving, of course, but it's been logistically challenging for patients. And so rates of screening compared to the number of people who should be screened, whose lives could be benefited from it, we're at about 10 to 15%. So that's another way of saying that is 85 to 90% of people who should be screened for lung cancer each year are not having it. And that's why we went ahead and invented a blood-based way of screening for lung cancer. Our blood test requires a single tube of blood. You get it during your routine visit with your doctor when they're probably checking other things like your cholesterol or something like that. And then the test comes back and it says, is there any evidence that you might have lung cancer and should you get a CT now? Or do we really not see any evidence of lung cancer right now? At which point you still need to talk to your doctor. You're still eligible for a CAT scan, but the test allows people to make a better decision about it in the moment.
Okay, that makes sense. So you mentioned 10 to 15% of people, only 10 to 15% get scanned. Is there a reason you think that it's kind of a low number? Is the cost preventing people, or what do you think is the main reason people aren't getting screened when they should?
There's a couple of reasons. One is it just takes a while for people to learn about it. We've had lung cancer screening available and covered by insurance for more than 10 years. Another is just these are people with lives and medical tests. A CAT scan, you have to go to a place, you have to have the CAT scan, you have to leave. It's a half a day any way you slice it, just because of the logistics. And so people are busy. And while it's really important for your health, people have a lot of things that are important to do. And generally, screening is not, never feels like something urgent to people. And it generally isn't, but you still want people to try and get it every year because it can be so life-saving. And so hence, we invented a blood-based way of screening for lung cancer. So at least when a patient's at their doctor and having their regular checkup, instead of having the doctor say, hey, let's see if you have time to get a CAT scan and having them not get the CAT scan for logistical reasons, they say, just you're going to go down the hall right now, or you're going to go down to the main floor and get your blood drawn. I want you to get this blood test too. And then we'll see if you have any evidence that maybe you have a lung cancer that we should go look for with a CAT scan. It's not insurance, although, of course, there are uninsured patients out there, and uninsurance rates very low in Massachusetts. But other than that, if you have insurance, annual screening with a CAT scan is covered fully. There's no cost out of pocket. They don't charge your deductible. And that's a law that was put in place. That's all part of the Affordable Care Act, or what people call Obamacare, that has guaranteed that coverage of that particular service, just like it does other screening services like colorectal cancer or cervical cancer.
Oh, wow. Yeah, I would have assumed that it's mainly the cost that's holding people back, but that's a
Well, cost
great.
is a big issue in healthcare, but in the instance of screening services that are recommended by the United States Preventive Services Task Force, which is a government program. Uh, they are covered without copay or deductible or coinsurance, so free.
Okay. Okay. And I guess just to take it back a little bit, tell us a little bit about your educational background. How did you choose to specialize in lung cancer specifically, or have you always?
So I'm a pulmonary physician, so, which means my specialty is the lung.
Mhm.
And I ended up in lung cancer completely by accident. When I finished my training program, which was at Johns Hopkins, I was moving to New York City because I'd gotten married to somebody who lived in New York and was working in New York. And the only place that would offer me a job was a cancer center called Memorial Sloan Kettering Cancer Center. Turns out a pretty prominent place.
Yeah.
And as a lung doctor in a cancer center, you sort of naturally say, well, what should I be working on? And the answer was lung cancer. And I've always been public health and population health focused. I'm trained as an epidemiologist as well. And so this was a logical place for me to do some of my work.
Okay. And I mean, how prevalent is lung cancer in terms of cancers worldwide and in the US as well?
We should be talking about lung cancer more. Lung cancer is the number one cancer killer of men and women in the US and globally by far. It is almost entirely, it is in that rate because of smoking and decades of smoking globally. Rates of smoking are still rising in parts of Asia. They're still very high in the eastern part and sort of the non-Schengen part of the EU as well. So a very serious problem. And as countries get into middle income levels, they start smoking more. The US smoking rates, fortunately, are in decline right now. So, but nevertheless, lung cancer claims more lives each year than the other cancers for which there's recommended screening all combined: breast cancer, cervical cancer, and colon cancer. Very serious problem. This screening test applies to a population that is older, 50 to 80, and has smoked somewhat considerably, 20 pack years or more. And if people are former smokers, if they've quit within 15 years, they're still eligible. That population's about 15 million people, so a small segment compared to our US population, but in that group are half of all lung cancer deaths. So that's why we screen that group. That's the group that the test can benefit right now. And all estimates suggest if we were screening that group, we would save 10 to 15,000 deaths. We would prevent 10 to 15,000 lung cancer deaths per year. To put that in perspective, it's a great story about cervical cancer that its rates have fallen and fallen. And now, of course, we have a vaccine. But the total cervical cancer burden compared to 130, 140,000 deaths from lung cancer, there's about 3,000 deaths a year from cervical cancer.
Okay.
So
Well,
lung cancer is a much bigger problem.
yeah.
Cervical cancer is important. Screening is important. The vaccine's fantastic. But I just want to sort of have your listeners understand kind of the magnitude of what we're talking about here. It's a quarter of all cancer deaths.
Wow. Yeah. So it was interesting you mentioned it once people reach mid-income, they start smoking more, you said.
Countries.
Countries.
So very poor countries, the smoking rates tend to be fairly low.
Okay.
But then once people start to have disposable income, the tobacco companies get in there in a hurry.
Right. Okay. Once they have the money to spend on cigarettes.
Exactly.
And because I was watching an interview you did where you mentioned that I think you were saying in the US specifically, people who are lower income are at higher risk to lung cancer. Is that?
That is also true. So yes, it's we're talking about two different scales here. Of course, the US is the second or third wealthiest country in the world right now. But as measured by GDP per capita. So even people who are poor, of course, have disposable income. That doesn't mean they're not living in poverty or anything like that. I'm comparing them to my earlier comment was about very poor countries where,
Yeah.
people with the average income is, less than $1 a day kind of thing.
Right.
So,
Right.
but no, within this country, poverty and lower income is positively associated with higher smoking rates, higher exposure rates to ambient pollution from, let's say, diesel exhaust and things like that, less safe environments that cause lung cancer from asbestos exposure, to other kinds of environmental risks. And all of those things combine to make the risk of lung cancer and therefore the risk of death from lung cancer much higher in poor communities than it is in wealthy communities. If you think about poverty or income level is the most powerful predictor of health. And this is just one of the ways that that turns out to be the case. And just to give you a statistic to think about, I used to live in New York. If you compare, as I mentioned, Sloan Kettering, if you compare the life expectancy of the wealthiest zip codes in Manhattan to the poorest zip codes in the Bronx, so 6 subway stops apart, it's 8 years.
Wow.
So, yes. And so that's not because New York's a healthier, a sick place. That's because poor people don't have money. They don't live in safe environments. They are at risk of many other diseases. They don't have healthy food and all the rest of it.
Yeah, like you mentioned that at the time, it's hard, to take time off from your job if you're working, almost every day. Go get these tests. Seems like kind of a snowballing, more and more.
That's right.
Uh,
Yeah, it's referred to as a time tax. So it's just another tax that, people with fewer means tend to pay, right? Not only not only different jobs and maybe more hours, but a lot less ability to plan generally. So, I'm a physician, I have a white collar life. I can plan something 3 weeks from now to go to the doctor and be pretty sure I'm going to not have something scheduled over it. If you're working in many of the industries that poor people work in, you have absolutely no control over that. At best, you'll see your hours on a Sunday for the week or something like that. So very hard to plan something 2 months in advance, like a CAT scan.
right, right. Do you have any, I mean, if you do you have any tips that you'd be willing to share if someone is lower income in the lower class, how they can kind of mitigate their risks of getting lung cancer, how to kind of live a healthier lifestyle on a budget, if you will?
Yeah, the most for lung cancer specifically, the absolute most important thing is to try and avoid, tobacco exposure or related combusted products, cigars, pipes, even, marijuana. These things are all associated. But, most particularly avoiding smoking, stopping smoking, reducing smoking. If you live in a household with other people who smoke, of course, encourage them, but also take steps to maybe have them smoke outside or something like that, improve the ventilation in the house. That is the dominant cause of it. Just as a thought experiment, if we never had smoking, and lung cancer probably the number 7 cancer killer, not the number 1 cancer killer. So
Oh,
still meaningful, right? Still a problem. But not this is tobacco cessation is really important. And for kids, preventing initiation of smoking is really important, in early teen years. If you can do that successfully, people are very unlikely to begin smoking.
okay. And it's just kind of going off that, what about secondhand smoke? Is that, you know,
Again, like if you live with somebody and
yeah,
you're constantly exposed, it increases your lung cancer risk relative to not living with somebody by about 20%. So it's not nothing.
yeah.
But compare that to somebody who actually smokes, their increased risk is 20-fold.
Whoa.
So, right, as opposed to 1.2-fold. So, not good, of
Yeah.
course. Encourage people to go outside to smoke, things like that. Roll down the windows if they smoke in the car, if you can. But, most important, encourage that, them, if you're your loved one or partner or whatever, to try and reduce their smoking, or which really helps, or of course, stop.
Okay. Yeah. And can you tell us a little bit about your time now at Delphi, Delphi Diagnostics with the first look test and everything that you guys have been developing?
Yeah, sure. So we launched the test a couple years ago now. It's called First Look Lung. As I mentioned, it's a blood test, and you meet with your doctor if you're eligible for screening based on what I mentioned earlier, 50 to 80, 20 pack years of smoking or more. If you're a former smoker, you've quit within 15 years, then it's an option for screening. If you haven't had a CT or if you're behind on your CT, you don't want to get a CT. Those are all options that would be a place where the blood test could be helpful. And then it comes back with a result, either elevated, meaning we're seeing some things. We look at circulating DNA, the DNA that floats around your bloodstream that comes from other parts of your body and just ends up there from circulation. And we can see if there's evidence there that lung cancer might be present, in which case the result comes back elevated. Doesn't mean you have lung cancer, not at all, but it means there's some signals there that we think need follow-up with a CAT scan. Or it comes back not elevated, means we don't see any signals of lung cancer. It is possible to miss a lung cancer with our test, of course, but once you have a negative result, the chance that you also do not have lung cancer on a CAT scan is about 99.8%. So that's a real number. It's not 100%, something to think about, but the technical term for that is negative predictive value. When our test is negative with a not elevated result, that's what it's 99.8% certain that if we ordered a CAT scan on you, we wouldn't find a lung cancer, which of course means there's a 0.2% chance we would. And if you and your doctor think your follow-up CAT scan makes sense, that makes sense to us too.
Okay. And where is it available right now?
In Massachusetts, it's available at the Leahy Clinic.
Okay.
Which of course is a premier place for lung cancer screening, a place we certainly have huge confidence in terms of the quality of the care of patients in their lung cancer screening program. They've been real pioneers in both early stage detection and treatment, and we're absolutely thrilled to be working with them.
Okay. Yeah, that's so most of our viewers are within driving distance of Leahy, so that's perfect. Um,
Fantastic.
do you guys have any plans for the future in terms of other hospitals where it will be available?
Yeah, we tend to announce them when those partnerships actually are going to
Oh,
launch. So I
oh,
appreciate
okay.
you asking those, Sam.
Okay, okay. How did you guys settle on Leahy specifically for the first one?
Well, like I mentioned, we're thrilled. Well, we're in a number of other health systems, none other in Massachusetts.
Okay,
So we work with Allegheny Health Network in Western Pennsylvania, Order of St. Francis in Illinois, and some others as well. So other large health systems. But like as I mentioned, we wanted to partner with doctors and systems that really understood early detection of lung cancer, and most importantly, if the test was ordered on a patient, they knew how to manage the results. They could get a CAT scan if it was needed. Then they could manage that CAT scan appropriately according to guidelines. Leahy is well recognized as one of the leaders in the country, if not the leader in the country for lung cancer screening. So like I said, we're thrilled to be partners with them. We're equally focused on this very important challenge and problem.
okay, nice. And so, what has been the biggest challenge in your role so far as the chief medical officer?
Oh, it's just a very exciting opportunity. And I've had a chance to work on our clinical studies. We're at the Food and Drug Administration now with our test. So I've gotten to work on those studies that the FDA requires. I've, of course, gotten to oversee the medical challenges and questions with lung cancer screening and gotten to know real leaders in the field over these years to try and customize the solution to the set of problems I mentioned earlier, which are the low screening rates. So it's just been a wonderful experience, and getting to have conversations like this is something I really enjoy.
Okay. And I guess you've touched on this a little bit, but right now, for all the people listening, who should really think about getting screened right now? Is it only people who are kind of in that age range and might have been smoking, or do you recommend that people maybe who haven't smoked but have used like the newer e-cigarette vapes or something like that, or should they be concerned about getting screened as well?
Yeah, lung cancer screening is reviewed by a federal advisory panel called the United States Preventive Services Task Force. That panel is the panel that sets policy for who should be screened for cancers and other diseases like hepatitis and things like that. And they recommend people ages 50 to 80 who've accumulated 20 pack years of smoking. That's smoking a pack a day for 20 years, or 2 packs a day for 10 years. That also gets you to 20, right? And current smokers and anyone who smoked, if they've quit within 15 years. That's the group for whom it's recommended. That's the group for whom there's full insurance coverage. And as I mentioned, even though it's only 15 million of our citizens, that's the group that comprises about half of all lung cancer deaths. And we're not screening that group well yet. We're only at, let's say, 10 to 15%. So we are focused on that group. That's the group we will run the test on. That's the group that's recommended for screening. Of course, I'm well aware that lung cancer also afflicts people outside that group, but currently we don't have the evidence to screen that group as well.
Okay.
You mentioned e-cigarettes. There's not much evidence. They're really new in terms of what damage they do to the lungs. But I'd say just as a general rule, as a pulmonologist, breathing in products of combustion is not good for your lungs. So I'm not a fan. Uh, and it's to me, it's very clear that it has the risk of leading people to then take up cigarette smoking, which, and as a gateway, it's quite concerning.
Right, because I do see a lot of people that might have and probably would have never smoked cigarettes, kind of right as at the time when cigarettes were becoming not cool, if you will, like people were just completely not even looking to them. The vapes came along, and then it's like, oh, well, this is the healthier alternative. So that was kind of the mindset that people had. I'll try this, and then like you said, it's kind of like a gateway to back to cigarettes, back to the thing that vapes were supposed to replace.
That's right. So yeah, um, as a doctor, I of course think about the carcinogens that are associated with smoking. But to be clear, the reason people use these things is not because of the carcinogens, it's because of the nicotine, which is highly, highly addictive. And so whether it's a vape or a pack of Marlboros, from an behavioral perspective, these are nicotine delivery devices. And so once you get somebody hooked, the same way I had a cup of coffee this morning, I'm not pleasant if I don't have one. I'm a coffee addict. In the same sense of the word, once you get somebody hooked on nicotine through the vape, you've opened up the door to them experimenting with other kinds of nicotine delivery devices like cigarettes.
Right.
And so, and that is the concern. But as I mentioned, Sam, even without that, um, you just don't want people breathing in stuff that's just been on fire, because it's going to be full of stuff that is not good for you. And it's, of course, why we have higher cancer rates and asthma rates along bus routes that have diesel exhaust, right? It's the combustion of the diesel and the particulate matter that comes with that that causes those diseases. So you're basically deciding you want to breathe out of the back of a bus pipe because it's cool. And I am not a fan.
So, is there anything to do with the geography of where you live? Like, say, if we're focusing on the United States, is there any regions that you think are kind of not, I don't want to say safer, but better to live in terms of avoiding lung cancer, some that are
Well,
more
pollution is
friendly?
a risk, but I think it's probably pretty clear. Like, there's lots of things we could do to make our environment safer, and a lot of the Clean Air Act work that's been done, since the Carter administration has been incredibly important in reducing the rates of respiratory diseases, including cancer. But first and foremost, it's lung cancer is caused by smoking. And so, if you look at a map of the U.S. where lung cancer is, it maps to where smoking is.
Hmm.
Yes, absolutely. Poor communities, we've made progress. So that's a little bit back and forth, cleaning up air quality, trying to switch to electric buses and things like that. So, we're getting there, but it's, like I said, if we could get rid of smoking, lung cancer would still be a problem, for sure. About 1 in 5 people get lung cancer today have minimal smoking history. So it's real, for sure. I'm not discounting it. But the rest of it is, it's important because we should have clean air for lots of reasons. But again, as a pulmonologist, the primary driver of why we should have clean air is childhood asthma, which is very disabling and
Hmm.
disabling to families. So because kids end up missing school and then parents end up staying home, et cetera.
Hmm. And I guess just to kind of pivot a little bit, but I know you mentioned that Medicaid and especially in Massachusetts, the insurance is very good and it covers a lot of these things. But in general, for healthcare, why has going to the doctor become so expensive? And is there kind of any solution to that in your professional opinion? Is there any cause of that?
I think, Sam, the that is a big question. It's probably a conversation for another day. But yes, the source of healthcare costs and the type of insurance coverage people have and why it costs so much out of pocket is there is a story there, of course, but it's far too much for us to try and get into today.
Fair enough. Maybe to be continued, maybe a different
I
day.
would look forward to that. That would be great.
Yeah. Okay. And we're kind of finishing up here. I don't know if did you want to talk about your and your wife's experience at all, or is that something you maybe want to talk about a different time?
It's very nice of you to ask. The For your listeners, I lost my first wife to breast cancer in 2012 and have written extensively about it in a few of the published periodicals. I think that also probably should be a conversation for another day, but I'm flattered that you're aware of it, and thanks for mentioning it.
Yeah, okay. Fair enough. Fair enough. Um, yeah, and then I think that pretty much covers everything that I wanted to ask, gives the viewers kind of a brief and very, pretty in-depth overview for the time that we had. I think a lot of people will learn something maybe they didn't know and go get
That'd be
screened
great.
if they need to.
That'd be great. Sam, thank you so much for your time, and I appreciate the questions and your interest in the importance of lung cancer.
Thank you so much for being here and answering all the questions perfectly and, with all the details we could afford with the time we have. I appreciate it.
Me too. Thanks.
Thank you.